So this one is the start of May 2023. Question number 1. Patient after road traffic accident, you are waiting for the patient for CT protocol and you notice that the patient got perioral edema and respiratory distress. His oxygen saturation starts to drop 72%, and what should be the initial management? Patient is waiting in CT, oxygen is dropped suddenly, hydrocortisone, intratracheal intubation, adrenaline, intubation has to be done. Sudden drop. Second question, massive blood transfusion, hypocalcemia, calcium is 2, other regulatory citrate toxicity. Patient with rickets, finding will be 25 hydroxycholic acid, low calcium, high B. Low calcium. Rickets, osteomalacia, calcium should be low. 50-year male recovered from myocardial infarction 14 days ago, developed sharp chest pain relieved by leaning forward, pericarditis VC showed diffuse, concave, ST elevation. What is likely diagnosis? Atrial fibrillation, aortic dissection, recurrence, and acute pericarditis. Chest pain is there, that's why pericarditis. Patient symptomatic came with a resolved transient ischemic attack. Upon investigation, found to have 46% carotid stenosis. How to manage? Carotid artery stenosis is there, stent is there, V is thrombectomy, endarterectomy. Observe. Stent, came with the result TIA, 46% carotid stenosis. It has got, it is D. Patient came to you after fall, after examination is unable to internally rotate and adduct his shoulder. Which rotator cuff? Internal rotation and adduction is subscapularis. Is there? Yes. 70-year patient was undergoing routine checkup with the radiologist, reported an abdominal aortic aneurysm 4.7. What is the most appropriate treatment? Surveillance under sonography. Then, which of the following substances is released from the sympathetic system to stimulate adrenal medulla? So, acetylcholine has to be released. Premature baby present with abdominal distension, bilious vomiting, nasogastric tube, premature necrotizing. Patient first had perianal discharge 3 months, and now since 2 weeks, the pain developed accounted weight loss, tender mass in the right iliac fossa. Crohn's possibility is high. Cardiogenic shock to give us marked contractility. What to give that has marked heart contractility and low vascular contractility? Heart contractility should be more, and vessels should not contract. So in this you have to give adrenaline, or it is dobutamine, which causes 55 only under laparoscopy, Roux-en-Y for obesity, post-operative day 1, tachycardia, abdomen. Post-operative day 1. Day 1 is atelectasis, or it should be yes. E has to be there. Why anastomotic leak? Post-operative day 1. On this question I will review it. Now going to question number 9 from the other group. This group. You have to go for ten onwards. It has to be 10 onwards. Yes, around half of the 50 questions might be there. Let us see. I'm scrolling it fast. Up to 9 we have done it. So that question, Roux-en-Y, second day, post-operative. Yeah. So it was ninth. No, this was 9. Not a risk factor of aortic dissection. So always you're getting diabetes in this. Little girl recently well from the fever, keeping pulling her ear. Mother notices yellow pus from the ear. Yellow pus is there, so Moraxilla. Sepsis scenario, what to give that has less beta 1 activity, mainly alpha. Beta 1 should be less, mainly alpha 1 activity. Sepsis, noradrenaline. Aortic dissection due to media elastin. Media elastin E. Okay, aortic dissection. Aortic dissection is intima. Aneurysm is media. What is diagnosis? Massive pulmonary embolism, myocardial infarction, pulmonary cardiac failure. So what is this picture? T wave inversion, QRST. T inversion is there. So it is what is the receptor does dobutamine act to reduce BP? Should be alpha 1 or beta 2. Beta 2 blood vessels. Vasodilatation, beta 1 receptors. Mainly in the heart, increase heart rate, contractility, definitely. Beta 2 mainly in vascular smooth muscle causes vasodilation, which can reduce peripheral resistance. Alpha 1 receptor causes vasoconstriction. Alpha 2 receptor pre-sympathetic inhibition of norepinephrine. Very correct. So B is the answer. It is beta 2 receptors. Patient with positive tenal sign, pain at night, median nerve, which muscle is affected? Abductor pollicis brevis. Smoker, ischemic heart disease, history of EVAR, now develop trash foot. Pulses palpable causes trash foot. Embolism is there, thrombosed EVAR, EVAR thrombosed. Painful thyroid swelling with defective epithelial cells and sideroblast. Thyroid swelling is painful. D. First texture pierced in the needle during CSF collection. In vertebral canal, ligamentum flavum, epidural fat, dura, posterior ligament, arachnoid. First texture pierced by needle during CSF collection in vertebral canal. So posterior ligament or ligamentum. Tough structure is ligamentum flavium. Prolapse disc asking about cause deficiency of which structure? Annulus pulpus fibrosis. Patient with chronic pancreatitis presents with pain in the back, what will be the appropriate treatment? Chronic pancreatitis, whether nerve block, NSAIDs. Nerve block, chronic is NSAIDs. Okay. Persistent nerve block. Okay. Fecal immunological test. Related question is sensitive, not specific. Fecal immunological test, biochemical test. Maybe specific and sensitive for detection of occult blood. Okay. Specific and sensitive explanation. Fecal immunological test, also known as immunological fecal occult blood test, detects hemoglobin in the stool using antibodies. Property description specific detects human globulin not affected by the animal meat, or sensitive can detect small amount of blood. Better can Goic blood test. Okay. Old Goic blood test less specific. Therefore, fecal occult blood is both specific and sensitive. Very good. Multiple randomized control trial using level. It is one evidence. Meta-analysis. Yes. Burn including both forearms and both anterior thighs. Both forearms only, not arms. Both forearms means 4.9, and both anterior thigh. Among leg, total leg is 18, and half of leg is 9, and that anterior thigh is again 9. 9 to the 18. So this is 18, and weight is fluid required in 24 hours. So 18 will roughly 20. 20 to 8 the 16. 1600 into 2 32. It is around 3.232. The question is not there. So burn including both forearms. Forearms means total, both forearms 4.49, both anterior thighs. So again they have become 4.5, 4.5, 9, 18 into 8, 36 into 8, 8 3 the 24, 2.3. Answer is A. Yes. 2.3, right. All thigh 9 circumference, all leg 9, both legs. Yes, this calculation is good. For scalp wound, adrenaline plus lignocaine 1% patient weight 50 amount of lignocaine. Now with adrenaline, it is 7. 7 5 is 35. 350 divided by 10, it is 35. Sudden severe tender abdominal pain. CT showed enlarged left colon. Little fluid in the peritoneum. Bloody plum colored stools. Tachypnea, tachycardia, raising lactate, no signs of obstruction. Ischemic colitis. No signs of obstruction. Lactate ischemia. 55-year-old patient, head injury, lost consciousness for 15 seconds. GCS, age is 55. GCS is 15, given instruction accompanying discharge. Patient. So this is the nice guidelines. So important is GCS 15 discharge, GCS 14 more than 14, even that can be discharged. 13 CT, 14 CT. From 13, 15 to 13, it is CT, 14. Patient came with DVT. What is the body physiological mechanism of keeping thrombosis in control? Protein C or plasmin? Okay, plasmin. What important factor that is increased and important in coagulopathy hyperfibrinolysis? Tissue plasminogen activator. This is the plasminogen is activated. Plasmin activator inhibitor, no. C is activated, protein C is also no. Major trauma associated with hemorrhagic shock leads to rapid and massive release of T from the cells. Tissue plasminogen activator. Plasminogen to plasmin, which in turn breaks down the massive surge of TPA. Activated protein C has been postulated as a major driver of TC circulating protein C is APC is anticoagulant. Effects of Diker and direct. Tissue plasminogen activator, because TPA is primary factor increased during trauma hyperfibrinolysis. 24 hours after routine aortic wall replacement for heavy calcified wall, patient